Welcome back. HIV self-testing was proposed as an option almost a decade ago, but there were concerns about it. In 2010, the South African Medical Association issued a statement warning that self-testing is in the absence of trained counselors could be a risk for newly diagnosed people living with HIV. In 2015, Health E-News reported that pharmacists were banned from selling self-testing kits, but this was lifted last year. This year, Medicine Sans Frontiers have been conducting a pilot study through the clinic in Khayelitsha to see how effective oral HIV self-testing would be and whether it could show an increasing in testing. Our city visited the clinic to find out more about that. Let's take a look.
I am a family physician and I've worked in Khayelitsha for many years, but 2.5 years ago I joined MSF in various roles, and one of them was to run a study on oral self-testing in the community because there are a lot of people who don't like facility-based testing and who don't know their status, and so we wanted to attempt to reach those who are not testing at facilities. And so that's how it arose. Now, oral self-testing has been around for a long time and it's been studied in many countries, but it's only in recent years that it's been rolled out as part of what we have to offer in trying to get people to test for HIV, because not everyone tests. And just in recent months, the World Health Organization put out guidelines on self-testing, not just oral, because you can do finger prick testing. And South Africa has also put out guidelines about self-testing and how it should be rolled out. But it is still early days here, and that's why we embarked on the study, just to see how it would be received, whether it was acceptable to people, whether it was easy for them to follow instructions, and whether it actually made a difference in them linking to care if they were positive.
This kit will come with this, and this is the actual test. You rub it at your gums, the upper gums and the lower gums, both sides, left and right, and there's a liquid here, and bear in mind it's not water. And after that, they put this test here for 20 minutes. They should wait for 20 minutes. And if there are 2 lines, this is during the waiting room area. There are 2 lines, and then the results will be positive. And then if there's 1 line, the results will be negative. Then I leave it there. Then on one-on-one session and the pre-counseling and just to more education and more, because this is a study, there has to be a consent form. And I explained the consent form. We went through the whole process of going through the whole consent form and the whole process of sending their SMS. So I give them all the pictorial guide that they need, all the information that they need. I also give them the numbers and I register them. All I need from them is their folder numbers so that I can register them on my register. And they go home with the kit. Depending on how busy they are, most of them will send the results immediately or the same day, because I also had a phone. Their phone is connected to our system, so immediately they send the results. It also activates on my phone that so-and-so has sent in negative results, or they have sent in positive results. So we also created that system in place to go in hand with this testing.
The recent pilot has been very interesting. We ran from March 2016 to March 2017, so it's only very recently finished, and we're obviously still looking at the data from the study. But it has brought out a lot of very interesting questions and a lot of good stuff. And so that's why we submitted an abstract to IAS Paris, and I went and presented it just a few weeks ago at the conference there, which was an international conference of the International AIDS Society.
This study is being conducted here in Khayelitsha. So we are trying to see if people are given an oral test study, an oral test kit, as a matter of fact, to go home with. Are they using it, and then are they coming back to confirm their results at the clinic? So I was conducting the study at Site B Clinic, where I educate people about the oral test kit, and they took it home with them and in large numbers, and we found out a lot of things after the pilot was done, that people are comfortable with the kit, and a large number of people would prefer it rather than the finger pricking one. And we also discovered a lot of information that we did not anticipate. We discovered a large number of females were using the test. A few number of males were using the test, even though it takes only a few minutes to register them on our register and then they take it home with them. The males are more reluctant. They still think that the process of getting the test takes too long. And we found out there are more excuses on the male side. We still have to do a lot of convincing. Most of them will call, especially those ones who will discover that they are HIV positive. We will call them to encourage them to come back to the clinic. A large number of them were in denial still. They still say that their results were negative. Some of them would not answer their phone. But we did discover them that this whole process of the study, or of them taking the kid home, triggered them in their mind to go to seek for help in other clinics. Or it kind of was like a wake-up call, so that they could be linked into care as soon as possible. So we discovered a lot of things. We also asked for their numbers there, if we could call them after a certain number of days. We said it was 7 days. If they did not respond with the SMS, to find out what were their results. And some of them were honest and say that my results were positive, and some of them did say that their results were negative. So we discovered a whole lot of things.
Well, our study was still fairly restricted to facilities, because we started with the concept before it was generally accepted in South Africa, and so we couldn't be too forward thinking because we wouldn't have got ethical permission. But basically we targeted people who refused the offer of testing in a facility, in a health facility. So it was only offered to those who refused the regular clinic testing, because we also didn't want to decrease the testing in the facilities. So this was already a vulnerable group of people who were not keen, for various reasons, to test at the facilities. We were very much hoping to target males as well, because there's a very low uptake of HIV testing amongst males, and we wanted to try and see what would make it easier for them to access testing. And so that's why we structured it in that way. But obviously, being a study, we needed to have follow-up so that we could look at results. And I think this resulted in some people not wanting to be part of the study because they didn't want any link there related to disclosure and stigma, and just fear of other people knowing if they were to turn out to be positive.
So the follow-up is to do confirmatory tests, so they come back to the clinic, especially if their results are positive, so that they could be followed up to make sure that they are linked into care, to make sure that their CD4 count is tested and their viral load is tested. So if there is a need, they could start on treatment as soon as possible. And also, if they are negative, we encourage their partners to come also and have the test, and they will also encourage them to come and confirm their results. That's important. And we also encourage them to test again in 3 months, and also to use condoms if they are not using condoms. Risk reduction counseling, so to speak.
Of course, self-testing is only part of the spectrum, and it actually is regarded officially as screening, so it does need confirmation. So that is the challenge that we need to get across there too, that people can test, but they need to then, if they get a result, confirm it.
When I asked some of the participants or the clients, they say it's much more comfortable at your own home to know yourself before you disclose it to anyone else, because the person who is the counselor, automatically you disclosing to them because they are the ones who are doing the testing. So they say that it's best if you know yourself, and then you decide who you want to disclose to, because you will find out we live with them, and we live here in Khayelitsha. So these are some of the people that are in our community. So they wouldn't want someone else who's a stranger to know. Maybe they might be connected to friends or a family member. So they are afraid of that stigma. They want to know themselves first before they actually disclose to someone else. So I would say they feel much more comfortable if they know on a separate space or at the comfort of their own home, not in front of everyone or not in front of a counselor. And they will find out, they say that if their results are positive, when they come out in their room, people will see their facial expression will be different. They don't want that process to happen to them when they come out of the room, of the counselor's room. So I would say those are the advantages of this oral test.
You know, it went really well and people really liked them, and they seemed to be able to do it quite easily in the privacy of their own homes. We would like to remove the hindrance of not wanting follow-up. So we want to make it more freely available, because I think what we've realized is that the easier it is to test in the privacy of your own home, the more people will do it, because they can then take responsibility for their own health. They can test when they want, and they can link to care when they choose. Of course, we're hoping that they will test and maybe be rather shocked or surprised at a positive result, will then retest, and after that's happened a few times, realize, well, actually, I need to link to care. So it's a process. It doesn't necessarily mean they'll link after the first test, but it's a process towards realizing maybe I need to take control here and access care.